Thank you all for coming today. I'm Dr. Joseph Ravenell. I am Associate Professor of Medicine and Population Health. I see patients at Bellevue Hospital in the Primary Care Clinic. I'm also the incoming Associate Dean for Diversity Affairs for the School of Medicine. So we're going to talk a little bit about colorectal cancer screening. Colon cancer is one of the most important cancers that we deal with in medicine because it's one of the few cancers where we can actually see a big warning sign that the cancer is coming, and we can actually do something about that warning sign to actually prevent the development of cancer. But it really requires timely screening. So we're going to talk a little bit about that today, about some of the options and how do we maximize quality of screening. All right, so I'd like to acknowledge that this presentation is from some of my colleagues who are part of the National Colorectal Cancer Roundtable. Screening for colon cancer saves lives, period. It's a complex process that achieves the maximum benefit for the patient when we do everything the way that we're supposed to, which includes not only getting the screening test done, but also following up. It does no good to screen and to find something wrong if we don't then follow up to do something about it. There is an initiative called 80% by 2018, and it's an initiative that we came up with at the National Colorectal Cancer Roundtable, basically where it's our goal that by the year 2018, 80% of age-eligible adults will be screened for colon cancer. Right now, nationally, we're probably closer to about 69%. We're a little bit higher than that in New York City, but we still have a ways to go before we get to 80%. So just want to encourage all of you, if you're 50 and older and of average risk and have not been screened, to please talk to your doctor about that. All right, so we're going to talk about the value of screening and then talk about some of the guidelines. Really answer the questions who, how, and when. All right, so some quick facts about colorectal cancer. 135,000 new cases each year, basically, and there were 51,000 deaths in 2011. Second leading cause of cancer death overall after lung cancer, and it can be prevented through timely screening. The incidence and mortality have been declining. We think that that's due to increased screening and increased access to screening. So where does colon cancer come from? Colon cancer develops over many years, basically from different types of masses called polyps. Polyps tend to increase with age, but it's really important because polyps often lead to cancer. And so if we can identify the polyps at an early stage and remove them, we can actually prevent the development of cancer. So this is basically what we're looking for when you have a colonoscopy. And a colonoscopy, as you know, is an internal exam or basically a very long scope with a camera attached to the end of it is inserted into the rectum, and it goes through your large intestine right up to your small intestine, and really visualizes the entire colon, looking basically for these polyps. And we think that it takes, on average, about 10 years for a small polyp to develop into a cancer. Prevention and early detection through screening, basically increased detection and removal of polyps leads to decreased incidence and mortality. We do have multiple ways to screen, and so for other modalities of screening besides colonoscopy, they don't offer the opportunity to remove polyps, but they do actually give us information that we need to do more testing. And basically, whenever an abnormal screening test is done, it's often followed by what's called a diagnostic colonoscopy to see what the reason for the abnormality is. So the United States Preventive Services Task Force, or USPSTF, is basically a group of scientists, experts, who basically review all of the available evidence about certain prevention topics. And so they've looked at many different cancers, including colon cancer, cervical cancer, prostate cancer, and they basically, based on the available evidence, basically give recommendations for whether or not tests should be done or should not be done. So when it comes to screening for colon cancer, it gets an A. That's basically the highest grade that this body gives. And so there's no question that colon cancer screening is beneficial because it detects polyps and allows us to promote the prevention of cancer. So how do we screen? I guess the first question is, who do we screen? So in order, and so what doctors take into account is basically when thinking about who needs to be screened, we think about their risk level. Are they average risk, increased risk, or high risk? What's their personal screening and surveillance history? What's their family history? What's their age, comorbidities, and just as important as all these other things is what the patient actually wants to do and what is consistent with their personal values. So we basically risk stratify to ensure that we are doing the appropriate test at the appropriate time. So we have these categories of average risk, which is basically you don't have any signs or symptoms of colorectal cancer, and you don't have any of the risk factors that we're going to talk about. When we talk about screening, screening is basically defined as doing a test when you are asymptomatic for whatever disease you are looking for. The minute you have symptoms, so for instance, if you have blood in your stool and you get a colonoscopy, that's not screening. That is a diagnostic procedure to figure out where the bleeding is coming from. Screening is when you do a test in the absence of symptoms, and that's what we are trying to achieve with colon cancer screening. So there's average risk, meaning no signs or symptoms of colorectal cancer, no things about you that increase your risk. Then there's the increased risk category, which means that you have a family history of colorectal cancer or polyps in a first-degree relative, or you have two secondary relatives who've had colon cancer. The other thing that puts you at increased risk is personal history of polyps, and in particular a certain kind of polyp called a serrated polyp, and we'll talk about this a little bit more. But so polyps, again, are the precancerous lesions that you can see in the colon, but not all polyps are created equally. Some polyps, and actually most polyps, are low risk, meaning that the chance that they'll turn into cancer is actually quite low, but then there are some high-risk cancers, some high-risk polyps, where if left alone, their risk of turning into cancer is actually much, much higher. So if you have a family history of polyps or colon cancer in a first-degree relative, or colon cancer in two secondary relatives, you're at increased risk. And then if you have a personal history of polyps, particularly the high-risk polyps, that puts you at increased risk. The high risk are if you have very specific gastrointestinal diseases, inflammatory bowel disease. The category of inflammatory bowel disease includes two diseases, basically ulcerative colitis and Crohn's disease. You guys may have heard about those things, but that group of diseases puts you at increased risk for colon cancer. And so how we screen and how we monitor people is different from if you are of average risk. And lastly, the highest risk, if you have a syndrome, basically a genetic syndrome where basically you are predisposed to having hundreds of polyps in your colon, those people need to be monitored and begin screening at a fairly early age, because if left untreated, those people will almost certainly develop cancer. Let's talk about the average risk category, which most of us will fall into. So we're going to answer these three questions. What is the best screening test for average risk patients? When should an average risk patient with a normal colonoscopy be screened next? And at what age should patients no longer be screened? According to the 2016 screening guidelines put out by the USPSTF, There are multiple screening strategies that have good evidence for their efficacy and their ability to detect abnormalities that can lead to the diagnosis of colon cancer. Different strategies, different tests have different levels of evidence. There's really no empirical data to demonstrate that any one strategy has a clear net benefit over the others. But many of us often prefer colonoscopy because it can be one-stop shopping, where basically you can not only detect the precancerous lesion, but you can remove it all in the same procedure. But there are other considerations such as how much it costs, whether you have access to it, and then not to be overlooked, patient preference. If you would prefer to do a less invasive test, there are very good options for you. So there are basically two big categories of screening tests. The stool-based tests. So we have high sensitivity guaiac-based test, or what was also called fecal occult blood test, basically where you take a little bit of your feces, you put it on a card, and then you can see whether or not there's blood in your stool. If that test is positive, it gives us a really big signal that there may be something going on, potentially polyps or cancer. Now, there are other things, such as hemorrhoids, that these tests can pick up, but because of our ability to detect and treat colon cancer, it's really important for us to make sure that if there's blood in your stool, that we rule out colon cancer. So there are a number of stool-based testing options. Then there are the direct visualization tests. Colonoscopy is probably the most commonly used one. It's the one that we definitely have the most experience with, and it also enables us to see the entire colon. For average risk people, every 10 years is what's currently recommended. Now, the minute you have something wrong on a colonoscopy, such as a polyp, that often changes. CT colonography is another modality that is newer, but basically it's also called virtual colonoscopy. So basically, it's a CAT scan that can look at the entire colon and essentially recreate a colonoscopy. That should be done every 5 years, and the experience that centers have with it is very, very variable. So if you're going to get that test, make sure that you are aware of the experience that the center or the institution has with that test. The other thing to know is the colonoscopy requires a prep where you have to clean out all of the stool from your colon so that they can actually visualize the walls of the colon. And you would think that with a virtual colonoscopy, you can bypass that step. But it turns out that you actually have to do the same bowel prep for a virtual colonoscopy. And there are many people who believe that the worst part of getting a colonoscopy is the prep. The most commonly used prep is this big gallon of stuff called Go Lightly, which tastes god-awful, but it can be flavored very well with, Kool-Aid or, grape juice or, something just to take away that kind of salty taste that it has. But it's really key to take the entire prep to clean out your colon, because if you get on the exam table and they insert the colonoscope and they can't see the walls, basically everyone's time is wasted. Most of all yours, because you often have to do the prep again and then come back. You have to reschedule it, and so getting a good prep is really, really key. Then there is the Flex-Sig, which is an older test, and basically the Flex-Sig just goes to visualize part of the colon, basically the most distal part of the colon. And so you don't get to, and so you're only basically seeing one side of the colon. Many people have cancers on the other side of the colon, and so you're missing that with Flex-Sig. So if you do that test, you basically have to do it a little bit more often than if you get a full colon. Great.
No, I mean, what is it?
Yes, great question. So FIT is one of the stool-based tests. It stands for fecal immunochemical test. Okay, it's basically a new, and thank you very much for pointing that out, that I didn't mention that. It's basically a newer stool-based test that is more sensitive and specific than the traditional guaiac-based test. That's actually probably what most centers are using these days because it is very, very specific to basically picking up the presence of blood in your stool. Guaiac tests, you can often have false positives if, for instance, if you eat beets on the day before you do a guaiac test, that can result in a positive test. Now, to go down the road of a colonoscopy because you had beets is just a disaster, right? And so we really want to know whether or not what we're seeing is actually blood. So that the fecal immunochemical test is super specific for blood in the stool. And so that's what most people are using. FIT DNA is even more fancy, where basically the DNA stool test, basically they detect the presence of DNA from basically the genetic material that is specific to cancer. Okay, so it's to polyps or cancer. So it's a very, very specific test, and so some people combine the strategy of FIT and stool-based DNA testing. As you can imagine, as you go down this list from the guaiac test down to the FIT DNA, these tests become more expensive and sometimes for that reason less available. But I would say that for the most part, people are using FIT if they go the stool-based route.
Flexible sigmoidoscopy
Mm-hmm.
with the FIT. Is the FIT a chemical, they're taking a chemical sample while they do the sigmoidoscopy?
So basically, it's doing the flex sig as well as taking a little bit of your feces and putting it on one of the FIT cards to see if it turns positive. Okay? Thank you so much for those questions. All right, so CT colonography, I'm not going to spend much time on that, but the key here is that it really requires the same bowel preparation. The other big thing to know about it is it's not covered universally by Medicare. So colonoscopy, virtual colonoscopy tend to be fairly expensive tests. In New York City, you can get a low-cost colonoscopy for between $400 and $800. I'm not sure for whom that's low cost for. Certainly not for me. So insurance coverage is very key. Very important to know that while some private insurers are covering virtual colonoscopy, most are not, and importantly, Medicare is not covering it. So we should definitely pay attention to that debate as it goes forward and as we're thinking about other health insurance issues. All right, so average risk. When do we screen people who are of average risk? Most adults age 50 to 75, and that's, again, the USPSTF has given that a grade A. In the elderly, screening is associated with decreased benefits and increased harms. So basically, all of our available evidence for people who are over the age of 75 suggests that it's a grade C, meaning that some of the evidence shows that it's good, other of the evidence shows that it either has no benefit or may be harmful. And that's basically what a grade C means. And so for this older age group, the evidence for the benefits are not as good. And so we don't routinely do it, but we take it on a case-by-case basis. And basically, because it takes about 10 years for a polyp to turn into cancer, if someone has a life expectancy of more than 10 years and they don't have other serious comorbidities, we actually strongly consider screening those people. I'm going to share probably more of my personal business than you care to hear, but my 97-year-old grandmother just moved in with me. I'm sorry, my wife's 97-year-old grandmother just moved in with us. And I wouldn't be surprised if she lived to be 115. Like, that's how well she's doing. So even though I probably wouldn't do a colonoscopy on her, It's someone that I would actually think very strongly about. And the reason that I wouldn't do it is because of her personal preferences. So basically, after the age of 75, it's on a case-by-case basis, dependent on your the best guess of your life expectancy. All right. So there's this big yes. Increased harm. So let me see if I can go back. But basically, increased harm means, and so there are certain things certain adverse events that can happen when you do a colonoscopy. Because you are inserting an object essentially into the rectum, there is a real risk of what we call perforation or tearing of the colon. The last time I looked, it was about it was less than 1% of the time that it happened. So it is a fairly rare complication, particularly in the hands of experienced operators. And so I would guess at a place like Bellevue or NYU, it's probably significantly less than 1%. But that goes up basically the older you get and the more comorbidities you have. It's also important to know that there are different types of anesthesia we use to make the test more comfortable and more tolerable, and certain comorbidities make the use of those anesthetic agents more risky from a heart standpoint. And so those are the harms that we think about. Sure. Oh, sorry. Big question, should African Americans start screening before the age of 50? So you guys may or may not know, but African Americans tend to have a higher risk of both getting colon cancer and of dying from it for reasons that we don't totally know. But it turns out that African Americans tend to get colon cancer at a younger age and tend to get more serious versions of it that are often less responsive to treatment. And so there's a debate right now about whether or not we should routinely screen African Americans before the age of 50. And the evidence is mixed, and so the guidelines vary. But one of the most important considerations is the fact that most insurers do not cover it. Just to put that out there. And again, the evidence is mixed, and so that's a debate that we should pay attention to, because my guess is that it will evolve. All right, so how should a patient with class 3 heart failure be screened? So this goes to the question of comorbid diseases, something that we always have to think about because of the risks of the procedure that we just talked about. So basically, if you have comorbidities that basically mean that your life expectancy is less than 5 years, then we basically we recommend not screening because of the increased risk of harm, number one, and number two, the fact that if we think that you're going to die of something else before 10 years, basically, then we don't really think that it's ethical to subject you to the risk of it. And then other high-risk conditions such as neutropenia, basically suppression of your immune system, often due to cancer treatment, unstable angina, that's basically heart disease, or other high risk for operative complications that we talked about. All right, so who's at increased risk? So this can be fairly complicated, but basically people who have colon cancer or polyps in a first-degree relative diagnosed at age 60 or older, or if you have two secondary relatives who actually have colon cancer. For those people, you should begin screening at age 40 with any test recommended for average risk. And you want to basically follow up at recommended intervals that we recommend for everyone else. Then the other thing that puts people at increased risk is if you have a family history of colon cancer or polyps in a first-degree relative diagnosed before the age of 60, or 2 or more first-degree relatives diagnosed at any age, then you want to start thinking about basically colonoscopy every 5 years starting at the age of 40, or 10 years before the youngest case in the family was diagnosed. So let's say, for instance, your father had colon cancer at age 46. That means that you need to start getting screened at age 36. Okay, so family history is really key, but your specific family history, i.e., was a first-degree relative, second-degree relative, did they have cancer or just polyps? All those things go into it, and it would be ridiculous for me to expect my patients to keep track of all this. So it's really important, if you have questions, to ask your doctors about what your particular risk is, because it can get complicated and these things change often.
Doctor, excuse me, the key thing is the second group to have a colonoscopy, not some other.
Absolutely.
Okay.
Yes, that's right. If you have a family history in a first-degree relative, there's no other screening test for you but colonoscopy. Thank you very much. That's true. Yes.
If someone had an adenoma and there already was dysplasia when they found it,
Mm-hmm.
and that was like over 10 years ago, 15 years ago, how often should they be screening the colonoscopy?
If they have normal ones after that.
If they had dysplasia over 10 years ago,
Age 46.
at age 46, and then they've had normal ones since then, I don't know that there is a very good evidence base for what to do with those people. My guess is that it does vary from gastroenterologist to gastroenterologist, but I would guess that they probably still want to screen you, still want to monitor every 5 years to make sure that another dysplastic polyp has not
And the age 75 limit does not
occurred.
apply in that case?
So I think you always have to take into account age 75 and what the expected life expectancy is. I think you always have to take into account those other risk factors before subjecting a patient to a potentially risky test. But again, because there aren't clear guidelines for that specific population, it's going to be variable from doctor to doctor. But thank you for that question. All right, so surveillance of patients with adenomas at prior colonoscopy. Well, you guys have ESP. So low risk adenomas, 1 to 2 tubular adenomas less than 10 millimeters, colonoscopy every 5 to 10 years. And again, these are guidelines. They're not hard and fast rules. And so I've definitely seen this vary, where people in this same boat get a recommendation for colonoscopy, in the next 3 years. And so these guidelines doesn't mean that that's wrong, but I just want you to know that guidelines are not hard and fast rules. They're just kind of exactly what it says. They are guidelines that help us to think about how we should do things in most cases. High risk adenomas, 3 to 10 adenomas less than 10 millimeters. We can kind of go through all these details, but if you're told that you have a high-risk adenoma, you definitely need more frequent monitoring. And then if you have more than 10, you definitely need to consider whether or not you have one of these genetic syndromes, such as familial adenomatous polyposis or HNPCC. And then any adenoma with piecemeal or possibly incomplete excision. So if your gastroenterologist didn't think that they got it all, you probably need to go back and look again, just to be sure. The last thing you want to do is basically leave something in there that could potentially turn into cancer. All right, so recommendations for adenoma surveillance after first surveillance colonoscopy. If your baseline finding has a low risk adenoma, and your first surveillance colonoscopy finding has a high risk lesion, then 3 years is the next recommended. If it's low risk, 5 years. If there's no adenoma found, then 10 years. For a high risk adenoma, if that's found at the baseline screening, if you then at the next one have a high risk adenoma, then it's 3 years. Low risk, 5 years, no adenoma, 5 years. So basically, once you have a high-risk adenoma, you basically should get every 5 years, okay? Again, that's, now once we get to the third surveillance, then our evidence base starts to run out. We just have to do the best that we can as far as trying to figure out what we need to do. All right, so serrated polyps, basically another high-risk polyp that basically is in a category by itself, where basically if that's seen, we know that that has a higher risk of turning into cancer than just the regular polyps that we see. So if we see a serrated polyp, the monitoring and surveillance is definitely more high frequency. This is just a quick graphic that just shows the natural history of colon cancer. Normal can change into a small adenoma, which can grow and turn into a large adenoma. Once these things get bigger, the growth kind of can start to get out of control. So we see high-grade dysplasia, and basically cancer is basically cells that are completely out of control and don't respond to the usual checks and balances that our cells have to limit growth. So the next, we can often see invasive cancer, and then metastases, which is basically when your cancer spreads to different parts of the body. And it's a very similar type of pathway for this class of high-risk polyps called the serrated polyps, where basically it goes from normal to kind of smaller polyps, bigger polyps, definitely to invasive cancer, and eventually to metastases. Yes?
Would the serrated grow faster than the 10 years?
So that is a great question. And yes, we think that these have the potential to grow faster than 10 years, which is why the monitoring is more frequent once you have a high-risk polyp.
I think I saw on your screen that at one time doctors thought that serrated would not become malignant.
That's right, yeah.
It's down.
So that's right. So yeah, so we now know that the serrated the serrated version of it can definitely turn into cancer. I'm going to so basically, if you have colon cancer, the surveillance after resection definitely varies, because I'm not an oncologist, I'm not going to go into this much, but you should definitely be very clear on what the plan is for surveilling to make sure that your surgery for cancer actually did what it was intended to do. So make sure that that's a very important part of the treatment, the surveillance to make sure that everything is taken care of, or to catch things early if it looks like things might be coming back. All right, so patients at highest risk, people, as we talked about, with inflammatory bowel disease, with basically ulcerative colitis or Crohn's disease, you really need to be monitored by a gastroenterologist who specializes in those diseases and in the management and surveillance of those diseases. And then for those people with a family history of either hereditary non-polyposis colon cancer or HNPCC, this is the one that I remember, or people with familial adenomatous polyps, they can have literally hundreds of polyps. And it's really important to start testing very early on, because those people have nearly 100% chance of developing cancer. And sometimes what these people require is to actually have their colon taken out as a preventive measure. So family history, again, is very, very key. So I'm going to end there. I don't think we have time to talk about prostate cancer, but I will just quickly say that there is a lot of debate going on right now about whether or not we should screen for colon cancer. The evidence about whether or not screening, I'm sorry, prostate, thank you, yes. The evidence for whether or not prostate cancer is beneficial in terms of increasing how long you live is very much mixed. So some studies show that it's not beneficial, and actually some of the larger studies that we've done suggest that it's not beneficial in terms of increasing life expectancy to get screened for colon cancer. And in fact, I'm sorry, prostate cancer, pardon me, thank you. Prostate cancer. Some doctors believe that actually testing leads to more harm than good. And that's because if you have a positive screening test for prostate cancer, it leads to more invasive testing that can lead to complications. But what's trickiest about prostate cancer is, unlike colon cancer, where we know, right, that early detection saves lives, the same thing is not true about prostate cancer. So most people, most men, and now we're talking about men, because women fortunately don't have prostates. When we're talking about prostate cancer, it's more people die with prostate cancer than from prostate cancer, okay? So most people with prostate cancer die from something else. And that's why it's so important to really have an informed decision or shared decision-making conversation with your doctor to really weigh the pros and the cons of screening, because chances are that even if you have prostate cancer, some people are not bothered by it at all. Some people do have very aggressive forms and they actually do die from it, but our ability to discern which versions people are going to die from versus which people are not going to die from, we're still not very good at predicting what the course of prostate cancer is going to be. We are much better at it, but we still have a ways to go. Now, you guys probably all know that that men with a family history and African American or black men have a almost threefold higher risk of both getting prostate cancer and dying from it. The challenge that we have is that most of the studies have not included sufficient numbers of black men, in my opinion, to make a sure recommendation about whether or not we should be screening. So what the United States Preventive Services Task Force now says is that for men who are age 55 to 69, that they should have a conversation with their doctor about the pros and the cons. And that high-risk men, such as black men or men with family history, those people should also have a conversation with their doctor about the pros and the cons. For men who are greater than age 70, USPSTF actually recommends against screening. One, because of the fact that most people, will die with it and not from it. And if you've made it to age 70, that the chances that you'll die from something else tend to go up. And all of the testing and potential treatment for prostate cancer, the risk of adverse events from those things goes up markedly after the age of 70. So thank you guys so much for your time and attention. I took longer than I wanted to. Dr. Joseph Ravenell, R-A-V as in Victor, E-N-E-L-L. I apologize that I'm going to have to scoot, but if it's okay with Shuba, I can take maybe 3 or 4 questions, and then I promise the rest of the session will be dedicated to cancer prevention in women.
Could you talk about the Cologuard thing that we see commercials? I mean, one of the challenges is to avoid colonoscopy because it's a horrible experience from
Sure.
A to Z.
No, great question. And so, as I mentioned, what Cologuard does is it basically detects DNA basically from abnormal cells, so either polyps or cancer. But like any non-colonoscopy test, right? The kind of common denominator is you end up getting a colonoscopy anyway, and so if you have an abnormal screening test, there's no way to avoid getting a colonoscopy. Even the best stool test in the world doesn't give us the ability to visualize what's going on and to be able to take a biopsy or to take the polyp out. And so even if you have a positive, and so where these non-colonoscopy tests are useful is if they're normal, right? And so Cologuard actually has very high, what we call negative predictive value, meaning if it's negative, you can be fairly sure that you don't have a polyp or colon cancer. And so it's okay to basically wait until the next screening interval to get screened again. But if it's positive, you still have to go on to get the colonoscopy.
If it's negative, then that's a sort of a reasonably clear indication that you may avoid colonoscopy.
So yes, that is a reasonably good indication that you can basically wait until the next screening interval to get screened. Yes. Let me get the hand of the gray shirt and the gentleman in the gray shirt, and then the woman in the pink blouse. Yes.
Regarding colorectal cancer,
Mhm.
are there differences in ground rules between male and female?
Ground rules, interesting. So by ground rules, do you mean as far as their likelihood of getting it, or kind of like what do you mean? I'm sorry.
Likelihood of getting it.
So we tend to see about equal numbers in men and women, generally speaking. But for some groups, and I'm most familiar with black men, the mortality rate is actually higher in black men than in black women, but that is due to a number of factors, including when the cancer is diagnosed. And so one of the challenges with men is that we're often not very good about going to the doctor in a timely way, and so diagnosis can be delayed. And as you know, for most cancers, the later you diagnose it, the harder it is to treat. Yes, ma'am.
Please define dysplasia and villus histology.
So, dysplasia, define dysplasia and villus histology. So, dysplasia is basically abnormal growth, okay? And so, I mean, that's basically our fancy medical word for abnormal growth. It's not cancer in that dysplastic cells still can be somewhat controlled, but it definitely has more abnormal growth than a normal cell. But we have to watch because dysplasia can progress. And so we definitely have to be very vigilant to make sure that dysplasia is not turning into cancer. Villus histology. So generally speaking, histology is cell type, okay? And so villus histology, villi, villus is basically, and you have to, I'm not a linguist, but I believe, villi is probably Latin maybe for fingers. And so villus histology, basically those types of polyps look like fingers. And those can often have a high risk of dysplasia. And so it's important if you get a report that says villus histology, you need to ask your gastroenterologist specifically what that means and when do I need to come back to follow that up. Okay? Yes.
When the primary care doctor had 2 years ago, he stated my age, I'll be 84 this year, so much risk for me taking colonoscopy.
Mm-hmm.
Another one 2 years ago said it isn't, so who do I listen to? My previous one, about 12 years ago, was found nothing. So
Mm-hmm. Mm-hmm.
who do I listen to?
Great question. So I think it's I think it's really important. This is where I think primary care doctors are kind of invaluable. And so if you have a primary care doctor, I would recommend setting up a visit with your primary care doctor just to talk about this. And what the primary care doctor should talk about is what are your values and your preferences, and then to also have a very frank conversation about what is your best guess of how long I'm going to live. Now, doctors are very uncomfortable talking about that because they don't want to kind of guess in the wrong direction either way. But if for instance, if you were my patient and you had, let's say, very advanced heart failure, or you were on dialysis, let's say. Those two things put you at very high risk of dying over the next 5 years, particularly in someone who is of advanced age. And so if I had a patient who was 84 who had one of those very serious medical comorbidities, I probably would not recommend colonoscopy. Okay, but it's totally on a case-by-case basis, and so you need to have the conversation with your primary care doctor that takes into account both your preferences and values and kind of what's the real deal medical picture, okay? I apologize. You guys have been an awesome audience. I have to go, but thank you so much for your time and attention.